So, and now once you inject it, now see, this is only a glucose saline, nothing else. So, as per the normal anatomy, when you put it intravenously, it first goes to the right atrium, then it goes to the right ventricle. From the right ventricle, it will go to the pulmonary artery. Then, because they are of a larger size, they get destroyed in the pulmonary circulation and do not come to the left side. And as a result of which, you see the LA and the LV are not at all specified. So that means once this is just a simple glucose saline goes to RA, RV, from RV goes to the pulmonary circulation. It is destroyed there because of a larger size. Nothing comes on the left side. So any opacification on the left side means that there is a shunt at that particular level. For example, here you see this is a parasternal long axis view. This is only to demonstrate because we knew that the patient has got a marked RVH and there is a VSD. So once we now this is a cyanotic child. Once we contrast, it will go to the right ventricle, and from the right ventricle, because it will go directly to the left ventricle and the shunt at the ventricular level, it will bypass the pulmonary and then go to the artery. For you see here, now we have given the glucose saline, it goes to the right ventricle and then goes to the left ventricle, bypassing the pulmonary circulation, and then it goes to the aorta. So that means that this cyanotic blood is going to the LV and in the aorta and produces. So this is like a VST. If you do it on an M mode, you will see from the right ventricle, it goes directly to the left ventricle through the shunt. If you see here, this is LV, this is RV. RV is significantly enlarged. You have given a glucose. It gives go to the right atrium and then it goes into the left atrium at the atrial level. So that means there is a right to left shunt at the atrial level. So there are multiple examples. You can see it goes on the RA, RV, but at the same time, it goes into the left atrium, indicating a right to left shunt. And sometimes these things may not be seen by a color flow mapping. So a contrast is one of the very important techniques to do these things or so. Anytime if there is any problem, please you can interrupt, and if you want to see any slide, again you can tell me later on. So now we come to the most important condition. This is the most important disease you will see in adults. That is the fellow tetralogy. Now, as I told you, unless you know the anatomy, you don't know what to see. Tetralogy means that there are three defects in there. Pentalogy means it will be 3, 6, 5, 4 like this. So, so like any other technique in echo, we have told you start with 2D, go to color flow mapping, and then Doppler. This we have been stressing you from day one. That this is always a sequence of events in this because this and in a congenital heart disease, we also see for associated lesions. Now, 2D anatomical features, as you know, as the name indicates, four things, tetralogy. One is a ventricular septal defect, large. One is aortic override, will show you RVOT obstruction, RVH. RVH because when there is severe pulmonary stenosis, it imposes a lot of strain. Any chamber which is subjected to increase the pressure or a volume increases in size and gets thickened. Now you see many things can be seen only from a parasternal long axis view. Again, I show you this is a normal case. There is a RV, this is aorta, this is a normal aortoseptal continuity, and this is an aortomitral continuity. You see, this is a normal case. Concentrate here. The aorta is not dilated and it continues with the septum. You see, now in a fellow tetralogy, you see here. Now, the RBS is there. You see there is a dilated aorta with aortic override. Override means that it is not in touch with this. It is going well beyond the this thing. So sometimes it is also known as a biventricular origin of aorta. Say biventricular means that a part of it is arising from the right ventricle, part of it is arising from the left ventricle, and then you see a ventricular septal defect. So very common finding, a presence of aortic override. Aortic override means that it is not in continuation with septum, but is overriding the ventricle, the septum, to come from both the ventricles. And so there are three things you have seen in this: an aortic override, number two, a large ventricular septal defect, and an RVH, if you can say this. So three things you have already seen. Now, this will show you later on when you always see for a pulmonary or a valvular stenosis in a short axis view. This is the area known as infundibulum, this funnel-shaped area which is coming from the RV to the pulmonary wall is known as infundibulum. So the obstruction can be at the infundibular level, at a valvular level, or combined. It is more common in infundibular region. So this we will demonstrate to you. So summary of 2D findings, what we have told you is a large malaligned non-restrictive VID. Non-restrictive means that the pressure in both the LV and RV is the same because aorta is arising from both the ventricles. Large aorta with aortic override, RVOT obstruction, which we'll show you just now, and a right ventricular hypertrophy. So all these findings can be seen in one single view. Now, after 2D features, always we come to a color flow mapping. And as we have told you, in a color flow mapping, it tells you the type of the shunt flow. It is left to right to left, and it to localize RVOT obstruction. Wherever there is an obstruction or disease, there is a increase, what is known as a increased change in the color, also turbulence. In mitral stenosis, the turbulence is in LV. In aortic stenosis, the turbulence is in aortic wall. So similarly, it tells you where it is seen. This all showed you. And then as usual, it guides the Doppler beam parallel to the flow. Now you see here, before this is a fellow tetralogy, aortic override, large VSD, mal-aligned RVH. Now you see, the red flow is the flow which goes from toward the transducer from the left ventricle, and the blue flow is the one which is coming from the right ventricle to the left ventricle. To make you understand better, now you see, this is the flow which is going from left to right toward the transducer, and this is coming from the right to left ventricle away from the transducer, red and blue. So this is known as a bidirectional shunt. That means it is both from left to right and right to left. So this is how we see for a color flow mapping. Then it also helps in RVOT obstruction of C. Most important hemodynamic present, most important factor in a fellows is a RVOT obstruction. There is something known as a pre-cyanotic fellows. When there is a very mild pulmonary stenosis, there will be no cyanosis. So it is the extent of the pulmonary obstruction which determines the flow and the shunt. For example, as I told you, the more the aortic, the more the severe pulmonary stenosis, the greater is the pressure in the right ventricle, and the greater the pressure in the right ventricle, the more will be the shunt from the left side. So that is why sometimes what happens, these fellows, they get relief by squatting. They squat on the floor So by squatting, the femoral artery gets clicked. So the systemic vascular resistance increases, LV increases, LV increases its pressure, and the cyanosis becomes less because left to right shunt is now right to left shunt is less. So most commonly it is at the fundibular obstruction, then this is valvular and combined this also. So always look for the remember one thing I very first day I told you any subject chamber subjected to increased pressure is first. Now the RV has to throw the blood. When there is a pulmonary artery obstruction, it has to increase its pressure to increase the throat blood. And when the RV pressure increases, there may be the reversal of the shunt. For example, here you see this is the pulmonary artery, pulmonary wall. There is no thickening or any doming, and you see this is the infundibulum, and this is a marked hypertrophy of the muscles. So this is obstruction. So you see the the turbulence starts from much beyond the mitral aortic, sorry, pulmonary wall. So the pulmonary wall is here, but the turbulence starts from the infundibular area. You see, it starts from the infundibular area and comes into the pulmonary artery. So this is an infundibular pulmonary stenosis. So that is why you see from where it comes and where it goes, the origin of this. In comparison to this, in a pulmonary stenosis, you will see it comes only from the pulmonary artery. This is what is known as the flow acceleration. Any flow which is going towards a stenotic orifice will have some change in the color. And here too. Now here you see there is no turbulence in the infundibular region, no turbulence in the infundibular region, but only at the pulmonary level. So just follow that at the where it will be seen. Will show you. Now this is a very important slide. Now see, this is a short axis view, zoomed view, tricuspid wall, right ventricle, pulmonary artery, and pulmonary wall. There is nothing here. There is nothing here. When there is a supravalvular stenosis, then you see a membrane coming here. This is just to show that pulmonary artery is completely free. But here you see, there is a pulmonary wall and there is a one membrane coming from here. So this is the pulmonary wall, which is normal, infundibular normal, and this is the membrane coming here. You just see where the echo is there, that is beyond the pulmonary wall. There is a membrane in the pulmonary artery. Now you see here there is nothing is seen here, nothing is seen here, but here you see a at this level you see. This is a supravalvular pulmonary stenosis, should not be missed. So that is why, as in aortic stenosis, you see at the aortic level, supraortic level, subaortic level. Similarly, in pulmonary wall, see at the pulmonary level and also at the suprapulmonary region, where you can this is membrane, is supravalvular membrane. So in Doppler, you have been told VSD. Now, there are two types of VSD, let us say restrictive and a non-restrictive. All small VSDs, they are a restrictive VSD, so there is a high velocity flow from the left ventricle to the right ventricle, and you see a tall Doppler pattern because there is a large gradient between LV and RV. In shallow tetralogy, because of the biventricular origin of the aorta, the pressures in both the chambers are almost equal, and so that you see a very low velocity flow. So this is hardly 1.5 to 2, and you see we have used almost a pulse Doppler to see it. So if it would have been a non-restrictive VSD, it should have been a tall going up to 4 meters or 5 meters or 6. So this is a low velocity flow because of an equalization of pressure between the two chambers. In shallow tetralogy, there is an aortic override which you have seen now. There is a VST which can be right to left shunt or a bidirectional which you have seen. RVOT obstruction which we showed you just now. RVH which we showed you present in all cases. Low velocity VSD flow, not a high velocity, and turbulence in the PA with a high velocity flow in that case situation. Now you see another patient. Again, here of course you cannot appreciate an RVH. There was an RVH, there is an aortic override, and there is a VST. Correct? So there is all the signs of this. Now once you see the color flow mapping, you see a red flow and a blue flow indicating a bi-directional shunt. So again you see all the signs: aortic override, dilated aorta, VST, RVH, bidirectional shunt, and here you see the turbulence coming from the pulmonary, much beyond the pulmonary wall, from the subpulmonary region. The patient had a subvalvular or a infundibular pulmonary stenosis. All signs of a fallow tetralogy you see because we had the turbulence start. But when you go further, here you see a left to right shunt. This is the left atrium, this is the right atrium. So one more lesion has been added into it, and then hence it is known as a Fallow's pentology. So that is why we always say never be satisfied with certain amount of lesions. Always go in detail. Again, you see, this is my method. I would have missed it unless I would have pushed my transducer up into the chest and produced more of the IES so that it is coming more towards the transducer as compared to the stand position. So this is a fellow's pentology. Now, this was a 19-year-old boy came to emergency in a very serious state, very drowsy, unresponsive, septicemia, hypotension, tachycardia, whatnot, cyanosis and clubbing of the nose. Oxygen saturation was 73% only. And this is just to show that the same patient had a marked cyanosis and the clubbing. So then you see, and the ECD shows marked RVH. You see tall R waves into the V1 and a very prominent uh, P waves indicating a RA enlargement. Now, as we have told you always, you see what you see in this patient. Now you can appreciate a much better RVH. This is all the RVH is here. The RV is enlarged and the LV is small, and there is sort of a jerky motion of IVS. You see. Now you see there is no aortic override. There is no VSD in this view. Only what we see RVH, RV enlargement and jerky motion. Now as you know, in a M mode, wherever you put an M mode, you can see in a 2D, you see the M. Wherever you put the M mode cursor, you see the M mode picture. So we put the M mode cursor here, and you see here, you see now the RV is 12 millimeters when the normal is upper limit is about 5. Then we saw a dilated RV, we saw a dilated RV. You see the paradoxical motion. The systole of the IVS comes here, while systole of the posterior wall comes here. So there is a completely the change. The diastole comes here, the diastole comes here you can see. So there is a paradoxical septal motion, but we just want to show that this is how you measure a RV that do in diastole, not in systole, and you see it was about 12 millimeters. And then same thing, you see what we told you on a pulmonary hypertension, there is a V shape or a flattening of the septum and a large RV. This indicates the presence of a large, very increased RV pressure. So everything now coincides with a significant increase in the RV pressure. And then you see in a short axis, there is a pulmonary wall and there is a membrane in the infundibulum, which is obstructing the infundibulum. So here the obstruction will be at the level of the infundibulum. So this is just to show that always see before the pulmonary wall, you see the infundibulum here. And you see again in the moving picture, this is the pulmonary wall and this is the infundibulum. That infundibular area consisting of a obstructive membrane. And you see marked RVH. This is all right ventricle marked RVH. So, and you see the gradient across it is about 77. So this patient had a pulmonary stenosis, a marked RVH, and you can see the gradient is almost about 77. And the same patient which we showed earlier, we gave a contrast which showed the left to right shunt. Now, this is the cause of the cyanosis. So you have to demonstrate a right side, a right to left shunt. Previously, this was known as the triology of fellows because it was containing three things: RVH, severe pulmonary stenosis, and right to left shunt. But now it is mainly known as the severe pulmonary stenosis with right to left shunt. It may be either through an ASD or it may through a stretched patent foramen oval. But the importance of this thing was to show you all the positive findings and how much the a contrast can help. Now, this I showed you earlier. This was a 727-year-old female having dyspnea, cyanosis, clubbing, and you see a large BSD, severe RVH, and this is just for demonstration purposes, RV large, and you see a predominantly right to left shunt, and then when you give a contrast, you find it is going into this. So there was a BSD with a reversal of the shunt. So this is what is known as an Eisenmenger syndrome. So Eisenmenger syndrome or a disease is a group of shunt lesions with severe pulmonary artery hypertension leading to bidirectional or the reversal of shunt. And the three most common are ASD, VSD, PDA. And between three, the most common is VSD. This is initially, ASD, VSD will have a high flow, but ultimately leads to a pulmonary artery hypertension and reversal of the shunt. So before labeling any patient as an idiopathic pulmonary hypertension, you must rule out any other associated lesion, especially any ASD, VSD, or a PDA. So that is the basic definition of the Eisenmenger syndrome. Any shunt lesion with severe pH leading to reversal of the shunt. Now coming to TGA, transmission of great artery, you will get it now. Concordance versus discordance. Once there is a normal connection, that is known as a concordance. Once there is an abnormal connection, that is known as a discordance. For example, suppose in TGA, the pulmonary artery, instead of RV, arises from the left ventricle. So this is known as a ventriculo-arterial discordance. So which is away from the normal one also. That is known as a discordance. Concordance is a normal one which will come to show you. Now, as you know, in transposition, the aorta rises from the right ventricle, correct? In the pulmonary artery arises in entire large part from the left ventricle. So there are two parallel circulation. Now what will happen? The One is the blood coming to the LA, goes to the pulmonary vein, goes to the LV, and then from there the pulmonary artery is arising from this. So this is oxygenated blood comes this. Other circulation is IVC and SVC. They they drain in RA. RA goes to RV. From RV goes to aorta, systemic circulation. This patient cannot live because only cyanotic blood is going into the systemic circulation. There is no way to mix the two. So as such, some communication must exist between them to sustain the patient. Because if one circulation is only arterial, one circulation only venous, the patient cannot survive. So this is how it looks like in a venous circulation, which goes from RA, RV there, and this is oxygenated one. There must be some connection, whether it is an atrial septal defect, ventral septal defect, or a VSD. So that means some of the venous blood goes into the left side and gets oxygenated. And this oxygenated blood comes there. So there must be a circulation between the two sides to maintain a life of the patient. That is why sometimes nowadays, whenever a patient of this TGA is born or so, and if there is no shunt, in the echo lab, they create an ASD. They create an ASD so that the child can survive. So what do we know? So there is an AV concordance. That means atria and ventricular are connected normally. RA to RV, LA to LV. There is a ventriculo-arterial discordance. That means the pulmonary artery instead of RV is coming from LV and the aorta coming from there. So you have to demonstrate this, and then there must be an ASD, VSD, or a PDA. It is a very difficult diagnosis. Remember, the artery which bifurcates into two is the pulmonary artery, and the artery which does not bifurcate into two is the aorta. And that will show you how it is there. Now you see this is the normal one also. Now when you take a suprasternal view, all the arterial branches are seen there because the aorta is slightly going anteriorly. Now you see here, and this is again the short axis view. Now you see here, this is a blood vessel which is coming from the left ventricle. I will show you. Now you see. So this artery also because it was a few days old baby, so imaging is poor. This is a parasternal long axis view. This is the left ventricle. This is the right ventricle, and there is one artery coming from it. We don't know which artery is it. We cannot say anything. When we put a color, you see it is bifurcating into two. So that means the artery which bifurcates into two is the pulmonary artery. So that means the pulmonary artery was arising from the left ventricle, and this is the this was the presence of ASD. Now this was almost 20 years back. Things have changed now. Now you see one of our cases also. You see this is a this is a subcostal view modified. In a subcostal view, you have to modify the view to see the artery. This is the right ventricle. This is the left ventricle. This is the left atrium. Right atrium will be here. There is one artery arising from the right ventricle, which we don't know what artery it is. There is one artery arising from here, which is arising from the left ventricle. We don't know which artery it is unless we see the bifurcation and the VSD is present here. Yes, the patient is cyanosis. Now, once you put a color, we still don't know because there is a one artery coming from the left right ventricle, one from the right ventricle. We do not know. We have not seen any bifurcation. Somebody can say, no, this is the aorta, this is the pulmonary artery coming from the normal ventricle. Further modification of the transducer now show the two branches, one going this side and one going this side. So that means this bifurcation means that this is the pulmonary artery which is arising from the left ventricle and the other artery which we see was there. And this we knew is a pulmonary artery because the pulmonary wall was thickened and it was steno. So, and you see there was a severe pulmonary stenosis. So this is to show you that we must show a bifurcation. Go to the view where the arteries are seen. Now, normally this would have been the RA and the LA, but we have modified the transducer and then slight modification of the transducer, you must see the bifurcation. And this, of course, the aorta. So this is a classical transmission of the great arteries. So atrioventricular concordance, ventricular arterial discordance demonstrate abnormal connection between ventricles and great vessels, which we showed. LV connected to a great artery that bifurcates in two branches, as we showed you just now. RV, great artery that does not bifurcate. Presence of ASD, VSD, PA. In first case, we showed you ASD, and the second one was VSD.
Sir, sorry to interrupt. Please
Yeah.
re-explain the previous slide.
Pardon?
Sir, re-explain the previous slide, sir, just before.
This one. This one?
No, sir. One more previous slide. Yes,
This
sir.
one?
Yes, sir. Yes.
So you understand it
Sorry,
better.
sir.
So you see, this is the right ventricle. In a subcostal view, this is the left ventricle. Now we have shown the artery which bifurcates is the pulmonary artery, which is coming from the left ventricle. If you see here, this is the normal, this is the right ventricle, this is the left ventricle, and you see these are flow. One artery is coming from here, one artery is coming from here, but unless we show it is a bifurcation, we cannot say whether it is a pulmonary artery or so. So if a modification of the transducer show that it shows a bifurcation into two, one branch goes this side, one branch goes this side, and then there was a pulmonary stenosis, and then you wanted to know this one. So this is the left ventricle, right ventricle. This artery which was showing a bifurcation was arising from the left ventricle and this aorta was arising from the right ventricle and a VSD is there. So you have to manipulate the transducer. It is very usually difficult case, but a subcostal and a short axis view can tell you once you are able to locate the ventricles, it is only the question of experience and the moving the transducer so that you can see the arteries also. Now you see this R, and this explained to you, this RA is connected to LV. So this is known as a atrioventricular discordance, correct? Because this is not there. The LA is connected to RV. That means it is an atrioventricular discordance. The pulmonary artery is connected to left ventricle. Aorta is connected to right ventricle, that is ventriculo-arterial discordance. So that means if you see this diagram to explain to you, this is atrioventricular discordance and ventriculo-arterial discordance. Now you see this is how I keep my LV on the right side, RV on the right side. This is the tricuspid wall, this is the mitral wall. As you see, the wall which slightly is going toward the apical side is always the tricuspid wall. You see, This is attached posteriorly, this is attached more toward this and LV side. So in this patient, you see this this should have been my LV, so there is a ventricular inversion. Now you see this valve is attached more toward the apical side. So this becomes the tricuspid valve. And the tricuspid valve is always attached to the right ventricle. This side you see, this valve is posterior. So that means this is the mitral valve, and so that the attachment. Now you see the pulmonary veins are connecting to this chamber. So the pulmonary veins that are connecting to this chamber mean that this is the left atrium. So the left atrium is connected to the right ventricle. So this automatically becomes a right atrium which is connected to the right ventricle. Now to prove, you see this is the pulmonary veins. So the pulmonary veins are coming to the left ventricle in this left atrium, and from left atrium they goes to the right ventricle, and then and so there is a further. Now why the RV is enlarged? Because it has become a systemic ventricle now. Because the 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 aorta is arising to the from the pulmonary from the RV, so that most of the blood is thrown by this. So this shows a atrioventricular discordance, and you see the pulmonary artery arising from the left ventricle side, showing a ventricular arterial discordance. This is what is known as a congenitally corrected TGA, and these patients are usually not cyanotic unless there are some complications. So that in this patient, what happens? The venous blood comes to the RA, the venous blood goes to the LV, and from there it goes to the pulmonary artery, and then it gets a it oxygenated, comes to the LA, oxygenated blood goes to RV and the aorta. So that is the sometimes rarely you can see. If you are whenever you if you are keeping your LV on the right side and you see something abnormal, so that means always see the attachment of the tricuspid and the mitral valve as to which is more attached to the apical side. Or if suppose we would have not seen this, we would have missed the case because you see this is attached here. I would have thought that this is the mitral valve, this is the left ventricle, but I keep my left ventricle on this side. So, but you see the attachment was important. So this is sometimes you may see, just forget about it. Instance we see quite a bit. You will also see quite a bit of instance. Whatever cases we have shown will be seen by you. Remember. Now, if instance we are mainly focusing on the AVI images to give you an impression. Now, Eastern's anomaly is a condition in which there is an apical displacement of the tricuspid wall, septal or posterior, from the atrioventricular ring. Apical displacement. Again, I come to the same slide. You see normal slide. There is hardly any difference of 5 millimeters between the tricuspid wall and the mitral wall. So they are just connected almost at the same level. But you see, in an Eastern anomaly, you see the septal leaflet is significantly displaced toward the apical side. It should have come from here, but it is significantly displaced. It's coming from there, and if you measure, it is 26.5. Ideally, it should be more than 8 millimeters per body surface area. In adults, it can be up to 14, 15, but here is about 26.5. So there was a significant apical displacement of the tricuspid wall. Next is there is an enlarged anterior leaflet. You see again, normal case. This is the small anterior leaflet. This is the septal leaflet. They move like this. Now see, this is the anterior tricuspid leaflet. It moves like a sail-like anterior leaflet. So in this slide, you see that there is a marked apical displacement of the septal leaflet, and there is a enlarged and significantly enlarged and a sail-like motion of the anterior leaflet coming up to this place. Form a mental impression. Left side is all right, no problem. The right side is there. Third is, now this you have to understand atrialization of proximal portion of RV, which is an important sign of instance for malformation. Now see, the atria is usually behind the annulus and the walls. So if these are the walls and this is the annulus, so this becomes the right atrium. So that remember the right atrium is usually behind the annulus and the tricuspid wall. Now, in a in a this instance, there are displaced tricuspid walls. RV is divided into two portions. Say one is a small portion, one is a large portion, and this is known as a atrialized right ventricle. You see, this is coming behind the tricuspid leaflets. So this is the atrialized right ventricle because in the right ventricle, while the atria, which is behind the annulus, is the true right atrium. So this is why it is known as atrialized because electrically and it is like a right ventricle. The right ventricle is small, but this is the sort of an atria which is behind the wall. So hence it is known as an atrialized right ventricle. This does not contribute to a stroke volume or so. The larger the atrialized right ventricle, the poorer is the blood output. Now you see here. Again, you see this is the normal person and the right atrium is behind this thing. On the rest, there is nothing in the RV. Now here you see, this is the atrialized right ventricle. Portion between the anatomic annulus and this becomes the functional annulus. This is the functional annulus, this is the true annulus. So this becomes an atrialized right ventricle. And the right ventricle is usually small and thin in these cases. Any doubt you can ask, but this you can automatically see that I have shown the numerous examples in which the portion behind the anatomical tricuspid is the right atrium, and this is a portion between the anatomic and the functional, or where they are meeting. This is the atrialized right ventricle, and this is shown here. This is the true right atrium. Here, the tricuspid walls are moving. This is the functional annulus. This is true annulus, and this is known as an atrialized right ventricle. So this is always present in these cases. It has to be present when there is a this. Then the tricuspid region. So you have seen apical displacement of tricuspid wall. You have seen enlarged right anterior leaflet. You have seen atrialization of the proximal portion of the right ventricle. Now the tricuspid. You see, the tricuspid wall always TR. This TR always comes from the valvular level. This is normal situation. But in instance, the walls are here. So the TR will come from there, not at this region. You see, you see the TR coming. This is known as an apical tricuspid regurgitation. So this is the atrialized right ventricle through LRA, and this is the apical tricuspid regurgitation coming from the apex. And this is the normal, this is because the leaflets are combined, are joining there. Then ASD or a PFO should be present in a majority of the cases, and you see, it is going from left atrium to right atrium. And you see, this is an instance anomaly because this is the septal displacement of the tricuspid wall, a sail-like anterior leaflet, It lies right ventricle, a, a true right atrium, and you see this uh, ASD coming from LA to this side. So this is about this. So you can see the apical displacement of septal leaflet, sail-like prominent anterior leaflet, atrialized right ventricle. This is atrialized right ventricle. ER coming from apical side, ASD, BSD. Now, when we were doing M mode only, then we were taught that in an M mode, there was no 2D probe also in 70s M mode. They said wherever you put it, your transducer, you can see a tricuspid wall. So think of this thing. Or, or whenever a child is born with a marked cardiomegaly, think of these things anomaly. So these are some of the features which you have seen. And in that case, you will definitely see in your day-to-day practice. Now, now, whenever any structure is absent, it is known as atresia. Or once they are small or underdeveloped, they are hypoplastic. So remember one thing, that absent means atresia. For example, pulmonary atresia with BST, that means there is no pulmonary valve also. And hypoplastic is small or underdeveloped. So this is almost up to 3% of lesions. So as the name indicates, atresia, tricuspid valve is absent, correct? Now, because the RB is normally fed from the right atrium and the tricuspid valve, when the right atrium and the tricuspid valve is not there, RB will be hypoplastic because his nourishment, this is like any of you, if you start fasting and everything, you will lose weight and you will become small. So that is because it is not getting nourishment from this place. The main chamber is left ventricle, which compensates for the enlargement. And there is no communication between RA and RV. Now I'll show you here one thing. Now the blood comes from RA, SVC, IVC. Now, if there is no shunt ASD, where will this blood go? Where will the blood come to the LA? Where will the blood come to the LB? Where will go to the aorta? So that the patient dies instantly within few seconds or so. So there has to be a shunt at the atrial level. Then there has to be a shunt at the ventricular level so that the blood can be oxygenated also and it should be hypoplastic. Now you see here, this is the normal pace. You see this is the tricuspid, my LV this side, RV normal size, LA, and you see this is the tricuspid valve opening. Now this is the tricuspid atresia. See, there is a dense band. There is no tricuspid valve. Compare with this. See, there is a tricuspid valve which opens into the RV, and RV is of a normal size. Here you see there is an equal dense band, and you see the RV is very hypoplastic. So the main chamber is left ventricle, and these are the pulmonary veins. So this is LA, this is LV. So there has to be a shunt, but which has to be present. Now see, this is audience plane. This is your plane. You keep sometimes LV on this side, RV on this side. I don't know which side you keep. So from those side you are keeping RV on this side also. You are keeping RV on this side. You see there is a dense band of a tricuspid valve which is not showing into this, and there is an hypoplastic right ventricle, and there is a atrium. So there has to be a shunt. Now you see the shunt has to be at this level. Now you see, despite a color flow mapping, we are not able to show a right to left shunt. But you see the pulmonary veins are coming. So this becomes the left atrium, this becomes the left ventricle, and and this is the RA, this is the hypoplastic right ventricle, but where is the shunt? So how is he surviving? In this way, there is no shunt. So this is the time when we give them a contrast echo. You see, a contrast echo shows it goes to the right atrium, and from the right atrium, it goes to the left atrium. From the left atrium, it goes to the left ventricle and to a hypoplastic right thing. So see, even in a color flow mapping days, we now here, remember, we could not demonstrate a good shunt from here to here. Because being an adult or so or something, but when we do a contrast echo, we see from RA goes to the LA and goes to the pulmonary artery, and then the same thing is seen. Another patient, no tricuspid wall. You can see this thing either an station wall or a Sherry network. Now you see here, the whole of the septum is seen. There is no ASD, and this is LA, this is LV and the mitral wall, and this is hypoplastic ventricle, and this is your view to show a complete absence of the tricuspid wall. It is like an eco-dense band, hypoplastic right ventricle, and you see a sharing a station, prominent station wall, but we cannot and chamber, but we could not see a good ASD with this. So again, give a contrast. Now this is before contrast. See, whole of the septum is well seen, and this is the absence of the tricuspid wall. This is hyperplastic right ventricle. This is LA, and this is LV. These are the prominent chamber. Now, when we give a contrast, see the same, which was not showing an ASD, the contrast goes from RA to LA, LV, and you can see some contrast bubbles in hyperplastic right ventricle. So you see still the contrast echo plays an important role, especially in adults also. So this is beautifully shown a contrast in the right ventricle, indicating a BST from here and a right to left. And you see here, it was looking as if there is no ASD or so. And then we see for associated lesions, sometimes you can see for BST, for external long axis view. Sometimes we see for pulmonary stenosis and UTC turbulence for a BST also. Okay. So these are, you can see, these are unrestricted BST because it is sort of a high velocity flow. So in summary, absent tricuspid wall, hypoplastic right ventricle, large LV compensatory mechanism, unprominent AV wall, presence of ASD and BSD and any other associated lesion. So these three cases you will definitely see in a day-to-day practice. So always go stepwise. Always go stepwise. There is never a hurry. See all the chambers, see all the walls. Never be in a hurry to see what. I think I don't know whether I've taken a talk on how not to miss a lesion by 2D echo. Single ventricle, univentricular heart. Again, now this child I saw when he was 8 years back, 7, one of the physician's nephew. Then I saw him when he was 34 years of age. Now I don't know where he is. So all hearts with atrioventricular connection to one main chamber. That means one chamber receiving both the tricuspid valve and mitral valve. If you see the literature, you can see a lot of definition for single ventricle. But a univentricular means that a single ventricle. Now you see there's a one chamber. These are the two AV walls. And they are virtually kissing each other in diastole. You see, there's nothing stopping them. You can see this is they are coming. The one attached to the apical side is the tricuspid, the attached posteriorly is mitral. And when you put a color on, you see both the flows, coming from this respective atria and mixing in the ventricle. There is no interventricular septum in. See, both of them missing each other, and just absence also. Very characteristic picture of a single ventricle. Otherwise, you'll see a septum. Otherwise, in a normal case, the mitral flow will go to the left ventricle. The tricuspid flow will go to the right ventricle. But here they are mixing in between. And then many of them are associated with a pulmonary stenosis, and we see a turbulence in the pulmonary wall. And you can see here you can be just modification of the transducer. Now this is a difficult one. You want to see or not? Now this is just uh, a anomalous pulmonary venous connection. As the name indicates, normally the pulmonary veins go to the left atrium, but here the pulmonary veins go to the right atrium. It is known as total when all pulmonary veins drain to right atrium or any systemic vein, forget about it. Partial when one or two or go to the anomalous connection. Now, what is the main echo features? Marked enlargement of right atrium because it works like an ASD. So like an ASD, the right atrium is enlarged. When the right atrium is enlarged, RV is enlarged. LA small. Why? Because LA is not getting blood from pulmonary vein. Like you saw in tricuspid atresia, there was a small right ventricle because it was not getting blood. And then one thing is this, I will try to show you there is an echo-free space behind the LA, which is known as a venous confluence or a sinus or so. It's a very serious condition. Suspect when there is cyanosis and cardiac failure and unprominent and large RV and small LA. When there you see a large RV, small LA with a cardiac failure, think of this. Now I'll show you all four veins not connecting to LA. They join together to form a venous confluence. See. Now, this was actually a case to develop the cyanosis later on. Now you see, I'll show you, you'll understand later on. Don't get worried. LV, RV, RA, ASD, and there is some chamber where my arrow is there behind the left atrium. You see, some chamber which is behind the left atrium where the pulmonary veins go. Now, to show you again, this is a normal individual. You see, this is LA wall, nothing behind it. There's nothing behind LA wall. But here you see, there is a chamber like this. This is known as a venous confluence or a venous chamber where all the pulmonary veins go. And from there, they go to a different place except the left ventricle. This will be well seen in other views also. You see this. Again, you see this. There is nothing behind the left atrium. But here you see, there is something behind the left atrium. Similarly, in a subcostal view, you see this is the left atrium, and this is a venous confluence and echo-free chamber behind that. So, and you see what happened, the blood is going into when the pulmonary veins are going into that chamber, but it is not going into the LV. You see, ASD, this is the chamber behind which LA is going, and then it is going to the other chamber, but not going to the LA. That is why the LV is hypoplastic. And then, of course, we show there are supracardiac diaphragms, we don't know. So all these abnormal veins connect to the superior vena cava, and because on the superior vena cava they go to RA, so the RA is enlarged. Now you see the surgical, then you will understand better. Now you see, surgeon has closed the ASD. Now you see, this is the venous confluence. This is the one. Now you see, establish unobstructed communication between pulmonary vein confluence and RA. Because you want to create a normal condition, so the pulmonary vein must go to the LA and then close the ASD. What he has done is close the ASD, and this is the pulmonary confluence. He has made a slide opening from where the pulmonary veins will go to the left atrium and go to the left ventricle. So any echo-free chamber. Now you see here, now this is a modified view. You see it goes into the venous confluence and goes into the left atrium. It was not going. And from slide modification of the view, it is going into the left ventricle now. So this is the venous confluence. You can never miss this if you can see in a cyno child also. See, this is behind that. And this is an opening created to, 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 to see the blood going to the left atrium, which was not coming, and to the left ventricle. So marked enlargement of right atrium, right enlargement RV, small LA, echo-free says behind the left atrium, and pulmonary vein not draining in LA, but other sites also. So now forget we have finished. This is just a cardiac cause of cyanosis as per age also. That must be with you. This is something I got. This is known as aortopulmonary window. This is short axis view. This is aorta. This is pulmonary artery. As you see, there is a connection between the aorta and the pulmonary artery known as AP window, best seen from the suprasternal view. So always evaluate clinically ECG, X-ray, chest. No hurry, take your own time. No basic anatomy and hemodynamics. Have lot of patience. Go stepwise. By stepwise, I mean like what has been told to you, atrioventricular corner, ventricular septal, go to the apical view, see the attachment of the atria or the wall, see this thing. I think I don't know whether that lecture I've taken or not. Go stepwise what has been told, and always look for right to left shunt. In an apical view, see that both atrioventricular walls are open. They are opening into their respective chambers, and use contrast that what we showed you. Then last is my favorite sentence, of Weiss syndrome. A Weiss syndrome is a syndrome where this is our word point. So when you feel that there is a discrepancy between clinical or echo features or even the echo features themselves, or you see some finding, then you have to explain why this is present. So that is known as the ones you keep. For example, here you see parasternal long axis view, IVS is thickened. So, but when we auscultated, we found a systolic murmur going toward the left infraclavicular region. Then, if I now you can say that even in hypertrophic cardiomyopathy, the RV can be thickened also. So, but there is this IVS, and one of the causes of a IVS thickening is a presence of a severe right-sided lesions. So, but that is not the thing to show. Now, and you see there is a flattening of the interventricular septum, D shape. This indicates that there must be much severe pulmonary hypertension. As you see, the RV was thickened, the IVS was thickened, flattening of the interventricular septum. So that means there should be a significant increase in RV pressure. But when we saw from other views, the the gradient was coming only 59. That is from the short axis view at various levels we find. So we felt that this is not consistent with our findings. See, of a seeing such a thick RV, thick LV, and the presence of a turbulence, but and a short axis view showing a D shape, but this is only 59. So, and the same patient showed what he showed is one interesting feature. There is a doming of the cusp and a subpulmonary membrane. You see the doming of the cusp, here pulmonary wall, and there is a subpulmonary membrane. So that means there is an obstruction of two lesions. So what we did and what you should do is try to practice all views. This one case gives an example. So you see two obstructive membranes. So this gives us, I tried every method. This was only done about a few days back only. I tried every method, but the gradient was not coming. Then I went to the RV outflow tract. This is an RV outflow tract, and here we put this gradient, and here we find that it comes to 124 or 125. There it was 57. So this RV, when you do an echo like an RV inflow view, you direct the transducer superiorly like this. And then when you superiorly direct it, you will get a pulmonary artery, and then you can see this. So this is known as the Y syndrome. Anything from your side now? Any clarification? Unless you go now today, our aim was to show you only the basic aspects, the images, which will always cast a, and you cannot get a better images than this, and how they look like, and then give you an idea. And this is a classical Y syndrome. I think today you should go and read these common conditions so that you can get a mental impression. If you can't get, then you let us know next time. We will show that image again to you. Ina, any questions from anybody?
Sir, anybody ask any question?
No, but this is one of the most
If no,
difficult topics. This
Sir,
is one of the most difficult topics.
sir, good evening, sir.
Yes.
Sir, I'm Dr. Alamin. So I want to ask you one question. First of all, how can we differentiate top from DRB? Is there any specific
Pardon?
point?
Pardon?
Sir, top from DRB. Tetralogy of Fallot to
Say DO, say I did not show you DORB. Say they all come in differential diagnosis. A double outlet right ventricle is when one full one artery fully comes from the right ventricle, other comes at least more than 50%. So that is more, both these, so number one, there may not be any aortic override. VST will be present in those cases. And if you can trace the arteries, they will be coming only from the right ventricle. And next is that there is normal in a fellow, there is a mitral aortic continuity, while here it is a mitral aortic discontinuity because of some conal tissues also. So there are ways to
sir.
differentiate.
Sir, is there any echo there?
Eh?
Can I see? Sir, is there any echo of DORB here?
DORB,
Yes, sir.
which, acha, because I will have to search it, because I'll definitely show next time, because I thought that it will further confuse you or so, and because most of them are diagnosed in the early stages, so I will keep in mind. I'll show you. Don't worry.
Sir, otherwise, sir
Sir,
will
sir,
share him later on
another
DORB.
thing, sir. Sir, okay, sir, another thing.